exposure to loss grieving and death. We have our own, and then we have our patients and our patient families. So, this is just kind of a beginning. We don't have the answers yet, but we'll hope we answer some of those. Yeah, and I know the slides have a lot of information on them. I need to shorten them a little bit. But an actual loss is when you can no longer see or feel or touch, that person or that animal, that object. It may be the death of a loved one. It could be the loss of a limb, an amputation. And it's kind of funny, it says in the book also a lost job or something along those lines, but that's also kind of built into some of the others as well. And then a perceived loss, when you have the actual loss, the people around you who know you are aware of it. They have some idea of what you're going through. The perceived loss you may keep to yourself. It may not be something that other people realize you're going through at all. It can be something like a friend that you've had a falling out with and you're no longer friends. Maybe, I know when my oldest daughter was, I think between her freshman and sophomore years, she was a really reclusive, kind of quiet, be there but not be seen and heard too much kind of student. And her best friend moved away, and she really went into a big depression. And she would leave the house, and I thought she was at school. I would be gone to work, and then she'd come home and spend the day there. So around Thanksgiving, I got a call from the school, and they said, "Do you know that Chris has missed 30, or maybe it was 20? It was like 20 days of school." And it was, I think, maybe right after Thanksgiving. And I said, this semester? And they said, no, this month. So she had not gone to school at all in November. And so we had to deal with that and get things back on the right track and get her over that. But it was a big loss for her. Children or adolescents, anyone who's being bullied, can have some feelings of loss and that they have no status and avoid that situation. Others may not realize how severe it is. Usually, most of the time, other people do not understand how severe it is. The example in the textbook was of a woman who chose to leave a job that she did enjoy and was well paid maybe, and but she decided she should stay home and take care of her children. And so she did that, but she missed maybe some of the satisfaction that went with her job, the independence of having her own money and not being reliant upon her husband, and maybe had a little trouble adjusting to that, no longer having that financial independence and that status. Her status had changed, and she probably didn't see her friends from work as much, so she had received loss. Anticipatory, and this is a good thing that people do, is when you know that someone that you love is going to die, or that you yourself are going to die, a lot of people kind of visualize or take themselves through it. Some people plan their funeral, write their own obituaries, are very detailed about the music they want, and they kind of work through the process emotionally so that when it actually does come about, they're ready, and it's not difficult. If this is someone who, maybe with a terminal illness and they know that what's coming. Now family, maybe, maybe my parent has advanced cardiomyopathy, you can't do a bypass doesn't help cardiomyopathy, he's too old for a transplant. There's just not anything really that could help my father with, he doesn't have cardiomyopathy, but he did. And if I started kind of thinking about what's life going to be like when Dad's gone, you know? What, you know, how I will miss him and what we will do about the cattle and, you know, how things will be different when he's no longer there, you know, and those words of wisdom that most of us, you all may still be too young to appreciate that, but I got through that phase where my parents didn't know anything, and then I got to the phase where I did ask their advice and get back to appreciating the 30 years on this earth had brought them experiences and wisdom that could help me. So I would have to adjust to that if I were in an anticipatory grieving process. It helps, however, some families do this, some people, maybe, let's just say it's me. I do all this anticipatory grieving to the point that I think about my dad as he's no longer there. And maybe he's in the hospital and in his last weeks, and I don't go visit him very much, or I just talk about silly things, what's on TV, and unimportant things, my new haircut, and just act like the world's fine when he's lying there dying. That's carrying it a little too far. So, and you do see that sometimes. Sometimes family will talk about the person that's dying as if he's already dead while he's sitting there, and say, well, you know, we're gonna have to get rid of some of that all those old tools, you know, which brother's gonna want those tools, and we need to clean out the garage, and these things, and those are his precious belongings that he spent many years with, so you really don't want people carrying it quite that far. I had an aunt, and to be fair, she had a little dementia. She said she was about 75, and her husband was dying, and she said there was someone in the community that she said, you know, I think I could date old EFY. And I thought, I wanted to punch her, you know, because my Uncle Pete was sitting right there listening, you know, and looking at her. And she was talking about, you know, when Pete's dead, I think I might try to date old EFYs, you know. And I thought, oh my gosh, I'm going to choke you. But I didn't. But anyway. So anticipatory grieving is okay, but there's, you know, a continuum that you would hope that if people get a little too far into it, that they pretty much emotionally detach from that person. That's too far. Okay.
Mrs. Martinez?
Yes.
Did you want your PowerPoints showing to the students?
Yes, they're not?
No. We were listening to your stories and just waiting for the right time to ask you.
Okay. All right. Let me see if this is my, yep, that's my first one. Okay. So actual perceived. Oh, now you, there they are. Okay. So these are the three kinds of loss we just talked about: actual, perceived, and anticipatory. Okay. Now, situational these listed below are situational types of grief, but they're also actual. And we're talking about chronic illness, where someone has lost a lot of their dependents. That's an actual loss, but it's also a situation. Appearance, maybe I'm undergoing chemotherapy and my hair fell out and I lost 40 pounds and so I look like a stick, and I'm real self-conscious about that. I don't know why I put that in blue unless I just put that word in there. I might have done, no, don't know why that was blue. Okay. A job, divorce, so those are situational things, but they're also actual losses. And dreams, life goals change. Sometimes who you thought you were changes, and who you claim to be. Maybe you intended to be a physician, but you did not get accepted into med school, and you became a PA, or you became a physical therapist, you became a nurse practitioner, a certified nurse anesthetist. I mean, there's ways you adjust your dreams, but not everybody starts out from the age of 12 with a plan that ends up being exactly what they become. Sometimes it works that way, and sometimes it doesn't. And then there's some of us who, I'm still waiting for my plan. So it just hasn't come to me yet. like a piece of, maybe a sentimental piece of jewelry that's been in your family for generations, doesn't have much value in money, but it means a lot to you. Maybe it was your great-grandmother's, and then you remember your grandmother wearing it, and then it's now yours, and if you lost it, you might feel terrible about that. Some people, why, I don't know. To me, a car is just how you get back and forth, and a good car is a car that doesn't break down and has air conditioning. But to some people, a car is much more than that. You know, it's like they love their cars. So, in our homes contain, you know, all of those things we're kind of sentimental about, family photos and things that have been passed down. Maybe if you have children, little drawings that they wrote. If you lost your home to a fire or something, that would be, you would have grief about that. The familiar environment, it can be maturational, like moving away from your family home when you're 18, 20 years old and going off to college, going off into the military. Those could be maturational type things. Or being 85 years old and moving into an assisted living facility or a nursing facility. Now, that was mentioned in the book. To me, I don't know that I consider that maturational, but maybe it is, and I just haven't, in my mind, that's not how things are supposed to go. I know people lose independence as they age, and they have to accept that their bodies are not as strong and they can't do as many things as they used to. They might have to rely more on their family. And maybe if they don't have enough family and they don't have the support system, that is going to mean an assisted living facility or a nursing facility. But that's not automatic. I don't know the percentage of our people in the United States over 80 who actually live in a nursing facility. But I would guess it's less than 50%. I'll have to look that up. The other thing, suppose you have multiple sclerosis and you are 45 years old and you're no longer mobile. You can't even really, you have a supracute catheter for your neurogenic bladder. You have bowel incontinence. You don't have family that can help you, and you have to move into a nursing facility. It's always very sad to me when I see the younger people. Maybe I've seen a few traumatic head injury patients who were in their 30s who were in a nursing facility with people in their 80s, and it seems so, I don't know, depressing and discouraging to me. Some of them seemed pretty okay with it, and some of them don't. But if they're no longer safe to live on their own, due to loss of judgment and decision-making capacity, sometimes that's where they end up. There just aren't a lot of alternatives in this part of the country, other than nursing facilities. Then there are things where we experience a loss and have grief. If it's a bankruptcy and you lose, you wipe out your savings if you had any. Maybe something happened. Maybe you have a real small company of like 2 employees. One of those employees slams into someone with your only truck, and there's a big lawsuit, and they just take everything you have. That would be something you would have to work through. And we talked a little bit about fire wiping out your house and possessions, and tornadoes we see here in Oklahoma, of course. Just so you know, the lecture capture is still blinking. I remember to look at it. Okay. We are going to do an in-class activity. Let's see. So I'm going to use one of Mr. Bear's terms for sins and ask you to suspend belief to the best of your ability. And you can read this for yourself. I guess I can read it, but I want you to go through this little scenario and then write a paragraph to Hunter expressing your feelings. And Hunter has died, that it has just happened, and you want to talk to Hunter and tell Hunter how that happened. And they'll let your camera back on. I think we're gonna see that those are some of the things that, that our lecture focuses on. I hope it comes back where I was, pretty close. Been almost up and down, maybe we will be right there. I didn't go very far. All right. First slide. Okay. Next. So, grief is both is the culmination of the emotional and the behavioral response to loss. Bereavement is a subjective component. So when we say someone is in bereavement, that is subjective. Mourning is the behavioral response, the things that we can see about that person. And then we talked about anticipatory grief. So there are a few different categories of grief. I mean, to me, I guess there's normal, but then there are these that are not considered typical. The complicated or dysfunctional grief is someone who mourns for an extended period of time, more than a year. They can't really accept that this happened. Most often this happens with a sudden death. It can happen when that person was so really critical to your everyday life, was so important to you. The more important that person was to you, the more likely this is to be the case. But also it happens in those conflicted relationships. You know, maybe my sister has been a drug addict for 15 years, has been in and out of my life. And yes, I love her, but I kind of hate her too, because she's put my parents through hell, and she hasn't taken care of her children. So that would be an example of a conflicted relationship where I might end up having one of these complicated, persistent grief situations. It also happens if you don't have, maybe if you have multiple losses, one on top of another. You know, this situation, in my little scenario, you lost two people that you loved, so very suddenly, and then they were very young. So that would be multiple losses. Another thing is older people might lose their brother, you know, that's 2 years older. They might lose their best friend who's the same age. They might lose their spouse 6 months later. You know, they just have those compounded situations where it seems like it's never ending. And also that lack of support might be there's not a grief support group in your community, or you just don't have people you can talk to. Might be that sort of situation. The exaggerated grief is really a mental health problem. The person who is grieving probably is having a lot of anger and becomes self-destructive, and maybe obsesses on the grief. They can't let it go. They can't focus on anything else, and they may become suicidal or just do very risky things. Maybe they become very careless with their driving. Maybe they have a job that involves machinery, and they start doing things at work that are outside of the accepted methods of doing them, because it increases risk for everyone else, and it really is a mental health problem. And then I'm going to skip down to the mass grief. If this person really cannot function, they're not aware that they're have disruptive or dangerous behavior, so they act a lot like the exaggerated grief person, except the person with the exaggerated grief knows that they're doing it. They're aware of it. This person, it may be a little more similar, and they are not aware that they're out of line in their maybe they're performing very poorly at work and they don't realize it, they're missing deadlines, the work they turn in isn't up to their usual standards. Maybe they're just being rude to people and have no idea that they are. Maybe they're neglecting their children. Instead of a glass of wine 1 or 2 evenings a week, they're drinking, a couple of bottles or something. And so that would be mask. And then the delayed grief, this person acts pretty cheerful and happy, like nothing happened, because they're just walling it off because they cannot face it right now. So they can't grieve. But it's probably building up inside of them as they. Yep. Now, we're going to look at Kubler-Ross's stages of grief. And Kubler-Ross studied people who were dying of cancer. So her stages of grief are very well known. They're famous, really, and they're quoted, and they're followed by a lot of hospice. They fit when you know someone's dying, and that person, the family knows that person's dying, and they can see people go through these stages. The patient themselves goes through these stages, most of the time, and pretty much in this sequence. But it doesn't have to be in this sequence. They can go back and forth, and some people skip a stage and so on and so forth. But for the most part, they follow these quite a bit. So, if I got told today after work that I had a late stage pancreatic cancer that was inoperable and my life expectancy is 3 months, I would probably be in denial. I would probably say, that doctor has misdiagnosed me. I'm a perfectly healthy person. I feel pretty good. I've just had some minor issues with some abdominal problems, and maybe my clothes are a little off, but I'm gonna go to someone else, and this is all a joke. I could also do something to numb my feelings and just be in a stupor, so I could drink heavily or use some sort of a sedative so that I did not have to really be in reality. And I could not just pretend I didn't know it, but I could really kind of get it fuzzy and so blurry like it was a dream or something. So that's denial. People might think, has she, people who heard and then they saw me and I'm cutting jokes and laughing and, going about my normal life. Maybe I'm making plans for a trip in 6 months to Italy, and yet I'm not expected to live that long. So that would be the stage of denial. Then comes anger. And anger can be toward anyone in the environment. Most often, it is towards someone very close, or someone who is not non-threatening. And if I'm really, really angry about what's happened to me, I can be very demanding, very difficult to deal with, mean to the nurses, just a miserable patient, a patient from hell, if I'm in this anger stage. Nobody wants to take care of me. They whine and argue at the nurse's station if they find out they've got me, because I'm just going to make them miserable during their shift. And it can lead to guilt and low self-esteem. And I know in a different part of my brain that I shouldn't be acting this way. It's not like me to treat people like this, but I just can't help it. And a lot of people feel like I don't deserve this. I've been a good person. This shouldn't have happened to me. Another thing you see, we do see nurses have to deal with things sometimes when the patient's mad at the doctor, but they're kind of intimidated by the doctor. But they're not intimidated by the nurse. The nurse is seen as a non-threatening person because we try to make people comfortable and we try to show compassion, so we're easy targets. So nurses often are the object of this anger. And you have to not take it personally. You have to know that what they're really angry about is their diagnosis. They're not angry because the cup of tea that you just gave them, they wanted it warmed 45 seconds and you warmed it 45 seconds, but it took a little bit longer to walk the hall. Somebody stopped you and asked you a question, and as a result, it's not as hot as they thought it was, so they throw it, throw that cup of tea. That's not that you did anything wrong. It's just they can't control their anger. One of my friends, I guess we were in our 40s, and I was a nurse at St. Mary's, and her husband had this horrible, rapid growing brain tumor, and not just one, but multiple. And I don't remember his diagnosis, but he actually had lumps on the outside of his skull show up. And it was very rapid. And he was the nicest person, had always treated her like a princess. And he was so mean to her. And her name is Jody. And we walked out of the room and I'd say, Jody, I am so sorry. He does not mean, it's just because he knows you love him, you're a safe target. And she said, the doctors told me that, the chaplains told me that, the nurses have told me that, but it still hurts so much because he's never treated me like this, and I'm afraid this is going to be my memories of our 25 years together or 20 years together or something. So it is painful for the other people to experience. Have any of you lost a loved one who went through this anger phase? Conqua? If you haven't, I'm glad you haven't, because it's not fun. Bargaining. A lot of people do this too. After they get over the anger, they start bargaining, and sometimes these are people that never really indicated that they believed in a higher being, but now they start saying, things like, well, God, I know I haven't been a Christian up until now, but if you'll just let me live long enough to walk my daughter down the aisle or to see my son graduate, I'm going to be a different person. I'm going to donate to charities. I'm going to go to church. I'm going to witness, and I'm going to be totally different than how I've been in the past. I'm going to turn my life over to you. If you will just give me, 6 months more than the doctor said, so that I can be there for this important thing that's coming up. They're really attempts to, and then if they actually do get to the walk the daughter down the aisle, there's going to be something after that too, because this is someone who doesn't want to leave. They feel like they have more living to do. After bargaining, usually people get to a point where they think, that's just not going to happen. It's not going to work. It's when the depression kicks in. And maybe this individual will talk about the fact that they're not going to live much longer, or maybe they won't. Jennifer in Tonkawa was one of my clinical students, and I know she had a patient with fairly young guy with metastatic disease who was able to talk about it. I don't know, Abby, the man who was in similar straits that you took care of, if he talked at all about his situation.
Yeah.
He did? Okay. So we did have several people, fairly young people, around 60, to me that's fairly young, being told that their life expectancy was not long. They had metastatic disease in numerous parts of their body. And they weren't going to be able to pull out of it, but they could slow it down. They could give them a few more months and things. And it sounds like a couple, they were both willing to talk about what was going on. And probably with their significant others, they could even go far enough to talk about what would never happen. I won't get to see grandchildren. You know, we planned to go to Hawaii for our 30th anniversary. We're not gonna make it to our 30th anniversary. And these people often cry, you know, they may ask for time alone. If they're in the hospital, at times they may be pretty open to, you know, you need to come in and give them care and give them meds, give them a bath and things. Other times they may just say, look, I don't feel up to a bath right today, I just want to be left alone. So come in and just, only when you absolutely have to. You know, you see times of both things happening. Maybe sometimes they want company, and sometimes they want just to be by themselves and think about things that are going on. The last of the Kubler-Ross process is acceptance. And this is where someone says, okay, you know, I'm not feeling really hopeless and helpless anymore. I'm feeling like this is the circle of life. We are all born. Hopefully we get to be here for a few years and have loved ones, maybe have children, maybe have a job that we enjoy. But sooner or later, we're all going to die. So I guess my time came a little earlier or a little later, but it's now my time. And once they come to that point, they may be more up to having company. They may ask to see people that they turned away, you know, 2 or 3 days ago. Maybe one of their best friends called their wife and said, can I come up and see Bud? And he said, I'm just not up to it. I'm not up to it. Tell Mike I'm not up to it. And then today, 3 days later, he's like, call Mike, I wanna hang out with him, you know. So they're ready sometimes. Or maybe not. Maybe they think, you know, that's gonna make me cry, that's gonna make me sad, so I'd just rather not see people. Because I'm in an okay place right now, but it's a little tenuous. I don't wanna fall back into depression. A lot of times people at this point will make plans, they'll, you know, write their obituary or talk about music they want at their funeral, or they'll go over their finances with their spouse and say, look, you know, we need to do this and make sure when you get to the life insurance, if they have any, that you pay off the house and put aside as much as you can so the kids can go to college, if, you know, that's a possibility. They may be very practical at this point and talk about those times. And in their mind, in their quiet times, there's a lot of life review where they go back through and think about some things they did that were good, but some things they did that they wish they could do over. So it says here, you know, I want to fix my relationship with my sister. I want to apologize for not being more understanding with her, you know. And all in all, I've lived a pretty good life, but yet I do have a few things to kind of remedy if I can in the weeks I have left, and then I'll be ready to go. I know I'm going to go. Everyone else is going to go too. That's something that, as you're young, healthy people, that, you know, you don't really think about death that much, but, you know, the person sitting to your left, the person sitting to your right, one beside you, one behind you, they're all going to die. I'm going to die, you're going to die, everybody's going to die. Hope that's not too depressing, but it's really not, because it's a circle of life, you know? We know that we are mortal. So, death is not that threatening. It might not be tragic at all. Just depends on how you look at it. I'm going to zip back here a little bit on, okay. So I went back to the start of who there was, because I was talking about it from the perspective of a patient who's told they have very little time to live. Now I'm going to just zip through it a little bit more and let's talk about it as the loved one of that patient. So they sometimes have these denial stages too. They're sometimes the very first ones to want to drag their loved one to multiple doctors. They want to go to the Mayo Clinic, they want to go to Houston, they want to go here and there. Sometimes they go all the places. They're going to Arizona. They cannot accept. A lot of times the patient gets there, but their closest loved one is not there at all. So they're dragging them around the country trying to find someone who will say this diagnosis is wrong. And so they're not always on the same page. And that's to be expected because we're all unique individuals. And they may tell the neighbors and friends that come that, oh, he's going to be fine. You know, this one doctor, this you know, joke, he's a joke. He thinks he's dying, but we're going to Mayo Clinic and we're going to get the real story. So don't worry, you'll be fine. We'll be back in a week. You know, that's not unusual. The family may be the ones who the nursing staff has a lot of difficulty with because that loved one, if they're past that denial and they're angry that they're losing their person who means everything to them, they're going to be impossible to please. You know, his pillow is not straight. I asked you for a medium pillow. This is a soft pillow. The last one was a firm pillow. He needs a medium pillow. This blanket is not right. You know, there's a wrinkle under him. It's just light on, because they feel so out of control that they can't take care of this person and make them well. So they're going to kind of micromanage everything else that they can to try to make them feel better, and they're also taking out some of their anger on you. So we just kind of have to put ourselves in their shoes, I guess, a little bit, and realize that this will pass. They will come out of this. This probably isn't truly this nasty and horrible of a person. It's just what they're going through. And you just do the very best you can to work with them and be professional. I remember a patient in the ICU who was young. He apparently was a wonderful young man, like the valedictorian in the senior class. He's getting ready to start college in the fall. Good athlete, handsome young man, and he just well liked by everyone, active in his church. And he one day just had a massive headache and immediately full, just massive seizures. They took him, he ended up in Enid, and we had a really good neurosurgeon at that time. It was before Metaflight. And he had a brain tumor that was just wrapped around and dug in, and there was no, you know, they operated on it, but they said, there's nobody that can get this tumor. This thing is one of the nastiest tumors I've ever seen in the literature. And his parents said, he was an only child. And I was a fairly new nurse in the ICU. And one reason I worked in the ICU is I liked the patients, but I really didn't like families that much. Because, I don't know, I was new and I didn't know how to deal with them. And back then, they only got to come in, and we had this light that would come on. And they could come in for like 20 minutes every 2 hours, and then they had to leave. We had a charge nurse. I mean, she was on that 20 minutes like crazy too. She would run them out, 2 at a time, out, you know. Anyway, so I was like, okay, I can concentrate on my patients and not deal with families. But this family, because the surgeon always made me go with him when he talked to every family that I was taking care of his patients, and I did a lot of the neuro back then. And he took the nurse for witness, and also because the family would tell you things he said, and you could have to say, no, that's not exactly what he said, or I understood it to be this. you know, you were there for clarification. If you weren't with him, then you couldn't do that. But they said, you know, why is this happening to him? He's just the best kid anyone could ever ask for. He's so wonderful. He's our only son. Why is this happening to him? And I remember his mom to this day, and that was probably my first year out of nursing school, and I just felt so helpless I could do nothing to comfort her. And I think that's why I didn't like families very much, because sometimes, especially in critical care, a lot of the time our patients were gonna die, or they were never gonna be the same. They're neuro patients, and I couldn't say nice things because I wasn't gonna lie. So, anyway, I think that's why I didn't like families as a new nurse. I did not know how to be therapeutic. And family may go through bargaining, the family certainly will go through some depression, sometimes after the death, they'll get to this point. And eventually, you know, after they grieve for a while, they will accept and deal with what's going on. And so, now, variations would be getting stuck in a stage. And most often it's denial, but it could be a different stage. Going back to the previous stage that they moved through is common and pretty normal. And as I said, not all clients experience every stage and not all move through in the same sequence. So the role of the nurse. Emotional support with your presence. You may use silence because they may want to talk. You come in and you're nervous and you chatter a lot, they don't get to talk about what they need to talk about. So you do need to maybe fiddle around with the IV pump, take a little extra time, doing something that normally you could do very quickly, and you know, give them a chance to initiate some conversations. Ask them how they're doing, you know, just in general, and see if there's things they want to talk about. Do not support denial. You know, you don't argue with the client, but if they tell you this doctor's wrong and my husband's going to get well, you know, probably a safe answer to that is, you know, I understand that that's your belief, you know, and then get the heck out of there. Run. No, don't do that, but that's probably what I would do. Like I said, I never knew how to talk to families very well. Because I wanted to say, yeah, you're right, you know, but they weren't, so. But every now and then someone surprises and lives 3 times longer than the doctor said they will. It happens all the time. So you're not really supposed to feed into the denial, but you're not going to argue either. If they have been very angry and nasty with you, but this time when you go in the room, they're not, you know, you might bring it up. You might say, you know, Mrs. Jones, I could hear that you were very frustrated, you know, when I was in the room earlier, and I understand. I don't blame you for feeling frustrated with what you're going through, and then maybe they will be a little better sometimes. They might apologize, they might not. It's okay, whichever way they go. If it's a client, like I said, let them talk. And a lot of times they wait till the family's gone. They almost seem happy and relieved when the family's gone. Because maybe they're afraid to say that if the wife's in denial and the client's in acceptance, they're going to wait till she's out of the room to start talking to you about, well, have you seen people die? And you're like, yeah. Well, what's it like? Well, most of the time they go to sleep and they just don't wake up. Their breathing slows down, their heart rate slows down, blood pressure goes down, and they just don't wake up. You know, most of the time it's pretty, they're not aware. You just get tireder and sleepier and you go. So a lot of people will ask you what it's going to be like, and you don't know for sure, but you can tell them what you feel you're okay telling them. And when they say, you know, I'm worried about my kids, I don't know how my son's going to turn out, he's just at such a pivotal stage, you know, I'm not sure about some of the friends he runs around with, and, you know, just letting them vent about those kinds of things, because they're worried about their role. Okay, I'm a dad, and now I'm not gonna be here. My son, I remember one lady who said, because her husband had died young, she said, you know, my children are gonna be orphans. They're gonna be all alone in the world. And they were like, 18, 20, and 23. But that's still, when your parents are gone, you are an orphan at 23, and they're still your parents, so. All right, I think we will take a break. Let me look at 29. It is 1:29, so let's get back here in 10 minutes at 1:30.